Okay, so first of all what I want to do is just have a look at the hand, so looking from both the dorsal aspect and the palmar aspect, looking for any discoloration, any scarring. I'm looking for any abnormalities such as swelling, which could indicate a recent injury. Could be looking for Heberden's or Bouchard's nose, which are swellings at the dips and the pits, which could be an indicator of osteoarthritis, usually primary osteoarthritis. Also looking for nodules in the palmar fascia, which could be a sign of Dupuytren's contracture, or the fingers being held in any position. Okay, once I've had a look through the hand to see if there's anything abnormal, I would then ask the patient to do a series of movements. So first of all, if you could just flex your wrist, so bring it forward and then extend it back, perfect. And then bring your wrist back to normal and into the middle, so up like this, perfect, and outside for me. Then if you can circle it round in a circle, perfect. And then what I want to do is have a look at your fingers, so if you can spread them out for me, bring them back in, perfect, and close them, and spread them backwards, perfect. And then if you can put your little finger and your thumb together for me, perfect. And that's looking at the range of movement with the thumb as well. Then if you could just bring your thumb forward, so like that, perfect, and backwards, perfect. Bring it in and bring it out, and bring it round in a circle for circumduction. Okay, so I'm looking for any generalised restriction, range of motion, any crepitus, any restriction in range of motion could be indicative of a pathology if it's general, or a somatic dysfunction if it's more specific. We'll also be looking to see if there's anything such as deviation of the fingers, so if it's radial deviation, so towards the thumb, that's more indicative of rheumatoid arthritis, and if it's ulnar deviation out towards the ulnar, that's more indicative of osteoarthritis. And then I can go through the passive motion, so looking at the wrist flexion, extension, adduction, abduction and circumduction. And I can go through and look at flexion through the metacarpophalangeal joints and the interphalangeal joints, and extension, abduction, adduction and some circumduction. Then with the thumb as well, we get some opposition, some flexion, some extension, adduction, abduction and circumduction, as the thumb is a saddle joint. So after I've gone through the active and passive movements, I'm going to go on to my palpation routine. So first of all, I'm going to start just with the radius on the ulna, coming down from the forearm and towards the wrist, looking at the distal radiocarpal joint there. And there's an interosseous membrane and fibrocartilage triangle between the ulna and the carpal bones, looking for any discomfort. Any calluses could indicate a previous fracture. Then to palpate the carpal bones, I'm first of all looking for the carpal bone that dips in, which is the lunate. Then come immediately to find the scaphoid, which forms the bottom of the anatomical snuff box. If this is the carpal bone most commonly fractured, and a side effect of that is avascular necrosis, when the distal portion of the scaphoid undergoes necrosis because the blood supply comes from proximal to distal. Then I'm looking out at the triquetrum and the pisiform there, coming up to look at the hamate and the hook of the hamate. And we've got the capitate, trapezoid and trapezium, coming up to palpate the metacarpals. The fourth and fifth are the ones that are most commonly fractured, often in punching type injuries, and then the phalanges, which are most commonly injured, fractured or dislocated in things like throwing injuries, DIY or kicking. Okay, and after that I'm going to palpate the ligaments. So the first ligament I'm going to palpate is the pisohamate ligament, which goes between the pisiform and the hook of the hamate, and that forms the tunnel of Guillaume, which is the pathway for the ulnar nerve and the ulnar artery. The ulnar nerve can get entrapped in this site, so to test for this you can do a Tinel's test, which is just a tap over the area and see if there's any symptoms recreated, which would be kind of sensory loss down the little finger and the medial half of the ring finger. And this can be a condition called hypothena-hammer syndrome, which is commonly occurring in manual workers who are using the hammer a lot, which can lead to damage in this area. After I've palpated the piezohamate ligament, I can look through for the flexor retinaculum, which transmits the carpal tunnel. So that goes between the pisiform, the hook of the hamate, the scaphoid tubercle, and the trapezium through there, and that transmits the median nerve, also transmits flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and flexor carpi radialis. So what you can do to test for carpal tunnel syndrome is to test any muscles supplied by the median nerve for weakness. You can also do a Tinel's test over the median nerve, and what you can do is to get them to do a Phelan's test, which is putting the hands together and bringing them down to hold to see if the symptoms are recreated, or reverse Phelan's, which is when the dorsum of the hand oppose. So what you're looking for in carpal tunnel syndrome is you're looking for sensory changes to the lateral 3.5 digits, and also looking for weakness. This occurs generally in ladies who are either pregnant or have gone past the menopause, and manual workers, and it's more common in diabetics. The symptoms are usually worse in the morning, and the fingers can feel weak, and actual weakness can be displayed. In the worst case scenario, wasting can happen of the thenar eminence. To treat carpal tunnel syndrome, you can go from some manual therapy, some kind of stretching work, and to try and release off the flexor retinaculum. Cortisone injections are sometimes injected into the carpal tunnel, or finally a release surgery can be considered. It's also good advice to give patients wrist supports which hold the wrist in a flexed position, which can reduce the likelihood of morning symptoms. Okay, so after that there's just a general palmar fascia, and you have a V deltoid ligament, which is the palmar radiocarpal, the palmar ulnocarpal, and the palmar intercarpal ligaments on the palmar aspect. Dorsally, you've got your radiocollateral ligament and your ulnar collateral ligament and your dorsal intercarpal ligament, which connect, and the dorsal radiocarpal ligament, which connects the radius to the proximal row of intercarpals. They're not specific to palpate, but if you know the general areas, then that can be of assistance. And next I'm going to palpate the anatomical snuff box. So if I could get you to bring your thumb back for me. So the floor of the anatomical snuff box is the scaphoid. Then you've got the radial border formed by abductor pollicis longus and extensor pollicis brevis. And then you've got the ulnar border of extensor pollicis longus. And if it's tender in there, that's a good sign of a scaphoid fracture. Okay, so what I want to look at next is the extensor tunnels of the wrist. So the first tunnel is commonly affected by stenosing tenosynovitis, commonly in people that use their thumbs a lot, such as manual therapists or craftspeople. So what I would like you to do first to find the tunnel is just to press your thumb up against my fingers. That's, thank you, the tunnel 1, which transmits the tendons of abductor pollicis longus and extensor pollicis brevis. So to test for that, there's a test called the Finkelstein test. So if you just tuck your thumb into your fist for me, and then extend your wrist out that way, and positive would be pain going up into the forearm. Okay, and then the second test, second tunnel, is the tunnel which contains extensor carpi radialis longus and extensor carpi radialis brevis. So what I need you to do is just clench your fist for me, and then bring it over towards this side. Okay, and then I'm going to resist that movement. Perfect. So that's the second tunnel in there. You always ask your patient if there's any pain, because that could be a sign of tenosynovitis or any inflammatory disorder. So then what you want to do is test tunnel 3 and 4 together. So tunnel 3 contains extensor pollicis longus, and tunnel 4 contains extensor interstice and extensor digitorum. So what I want you to do is just put your hand on the table for me, okay, and then just press your fingers up. Sorry, tunnel 3 and 4. Then if I'm going to test tunnel 5, well, this is the tunnel for extensor digiti minimi. So what I want you to do is just press your little finger up into my hand. Perfect, and that's in there. Okay, and finally tunnel 6 transmits the tendon of extensor carpi ulnaris. So if you can make a fist for me, and then bring it this way, and then bring it over to this side, okay, and resist and force. Perfect. Okay, and that's tunnel 6. What I'm going to look at next is the soft tissue structures in the hand. So you've got your thenar eminence here, which are the muscles supplied by the median nerve. So you've got opponens pollicis, which opposes the thumb, and you've got abductor pollicis brevis, which abducts the thumb, and you've got flexor pollicis brevis, which flexes the thumb. They're all supplied by the median nerve via the carpal tunnel. If you get median nerve palsy, you can get wastage of the thenar eminence, which sometimes is a condition known as ape hand, and the thumb loses its ability to oppose weakness in oppose and flex and abduct, although adductor pollicis is spared as it's supplied by the ulnar nerve. Then you've got your hypothenar eminence on the medial aspect, which is the group of muscles of abductor digiti minimi, flexor digiti minimi brevis, and opponens digiti minimi, and these are supplied by the ulnar nerve. So an ulnar nerve palsy, you can get a sign called benediction hand, which is when you get flexion of the 4th and 5th digits, because the flexors of the hand work unopposed as the extensors are lost. Often you get atrophy through the lumbricals, and you can develop a condition called claw hand. So you get a hand that drops like this because the supply to the extensors of the wrist are lost, and so the flexors work unopposed. Okay, thank you very much.